So thank you very much for the invitation to speak today on what works with regards to adherence support. So we're going to think about looking towards the fourth 90. So I'm Michelle Croston, and I'm going to guide you now through the next 15 minutes where we think about what kind of works with regards to adherence support. So there's just some disclosures from me. So I've worked for lots of different people on lots of amazing projects. So when we're thinking about this session, Liz has kindly already explored the difference between intentional and unintentional adherence, and she's kind of articulated the key components of how we may work with people living with HIV who have experienced adherence challenges or adherence support needs. So the following session is going to look at a brief explanation of what we mean by the fourth 90 and how this may link with the concept of adherence. We're going to explore the evidence around adherence and how we best provide support for people living with HIV. And then in order to kind of conceptualise this, I'm going to bring it together at the end with a couple of case-based discussions. So thinking about the fourth 90, so for people in the audience, you may have already been familiar with this idea of the fourth 90. So for those who haven't, the kind of concept comes from the UNAIDS, who released these ambitious targets, which said that if we had 90% of people diagnosed with HIV, 90% on treatment, and 90% of people living with HIV virologically suppressed, then we could end the HIV epidemic. Great ambitious targets, and lots of cities across the world are definitely working towards this. But what was remiss from these targets was this element of quality of life, the kind of fourth 90, and what that might mean for people living with HIV. So when we think about the fourth 90, and there's lots of leading academics and clinicians now really kind of thinking about this aspect of quality of life, for me, adherence and adherence support kind of fits really nicely into this about kind of what do we mean by quality of life, and how providing people with support around their decisions to take or not take treatment, as the case may be, can really kind of have a positive effect on people's lives. So for me, I believe if we spent a lot more time concentrating on this kind of quality of life, then it'd have a positive impact on further down the cascade of diagnosis, treatment, and virological suppression. So how does that work when we're thinking about adherence support? So again, as I'm an academic and also a clinician, I like to kind of go back to the literature to kind of really draw on kind of what are the predictors and correlations of adherence to treatment for chronic HIV infection. So this work was done by an amazing colleague, looking at kind of a meta-analysis, so looking at all the literature out there to think about what actually do we know about the reasons why people don't take treatment. As you can see from them, there's lots of studies that have been kind of captured within this meta-analysis. And some of the key themes that came out from this and predictors, which Liz has already kind of briefly talked about, was this idea of self-efficacy, the belief that we can actually take treatment. Also, the idea of having some kind of substance misuse as well alongside that may affect people's ability to take treatment, kind of their beliefs about treatment and concerns about the treatment they're taking. Also, trust comes up quite a lot within the adherence support. And again, we're going to move on to talk about how we may, as clinicians and people providing support, help with that. Also, underlying mental health problems, which is kind of where most of my research and background in a clinical setting kind of leads towards, is how the impact of kind of mental health and poor impact of quality of life may be. For those who are working in HIV care or have kind of come into HIV care, we can't ever kind of separate this idea of HIV stigma and kind of what that means for people. And also not just HIV stigma itself, but kind of that self-stigma and the impact that that may have on treatment. Also within the literature, what came up was kind of the idea of social support. People who were better connected with other people kind of found it easier to adhere to treatment. Also, pill burden, the number of tablets that people were taking also impacted on their ability to take treatment. Okay, so how does this help us? So how do we, in our clinical environments or in our care providing environments, provide support to enhance people's adherence to treatment? So again, drawing on from the literature, the idea of creating these trusting environments. If you take a moment now to think of yourself and kind of having that ability to kind of be open with the people who are providing care for you about actually what you're doing. And this kind of feeds into those kind of safe environments. So if people don't feel safe enough to tell you they're not taking their treatment or they're struggling taking treatment, then you're not able to provide them with the support that they need. Also, what's really important, and definitely from a lot of the work that I did when I worked in HIV care, was actually thinking about somebody's readiness to start treatment. Whereas it may be something that we think would be a good idea for them to start treatment based on their kind of clinical presentation, actually this may not be a good time in their life to start taking treatment. So again, really spending some time kind of upfront thinking about, actually, is this a good time for you to start taking treatment? Again, feeding into from the literature, this idea of self-efficacy. Do people believe that they've got the skills to take the treatment that they need for a long period of time? And again, it's quite a good idea as clinicians to kind of really promote that idea that actually you're doing really well taking treatment, or you having that belief that somebody can do that for themselves. The idea of developing decision-making skills. And if you think back to yourself, we can go along better with decisions that we think we're better involved in. It's just part of human nature. Nobody really likes to be told what to do or told that they need to do something. So this idea of trying to support people to make decisions about their kind of health and well-being. Again, thinking about providing education. And again, sometimes we think that we've got time-limited consultations. And definitely today, thinking about having up to 15 minutes to discuss some kind of techniques with you today, really have to think about actually what do people know already? And actually where could your education fit in with that, kind of filling in those gaps. And again, thinking about some kind of techniques now. So moving on from the basics of what we can do, maybe some things that may need further training, the idea of motivational interviewing, finding out where they are in that kind of cycle of change from like not wanting to take treatment, trying to build that into their lives and really supporting them with that. Again, thinking about the idea from the literature about this kind of beliefs around treatment. Would cognitive behaviour therapy be useful to help? And again, this may not be the skills that you may have as a clinician, but it may be or somebody providing support. But again, it's useful to know that you could signpost people towards kind of therapists that may have those skills as well. And again, fundamental to working in this kind of way, this very person-centred way, is the heart of all decisions and making them part of what we call this shared decision-making. So enabling people to kind of own the decisions they make and supporting them with the relevant choices that they have. Underpinning all of these techniques for me is this idea of a compassion-focused approach. So really understanding that actually from the talk that Liz has kind of excellently delivered, that actually people sometimes can't take treatment for whatever reason, and actually getting alongside somebody and trying to kind of really think about what would be useful for them during this time as well, and maximising that the time you have. Now, thinking about this from a kind of case study point of view, how does that fit in? So I'm just going to share two examples from my clinical practice. And again, these are the patients' names have been changed in order to maintain confidentiality. So this was Sanju, he was 49 years old, Ugandan man. He was diagnosed HIV positive 5 years ago. He started on treatment initially and was doing really, really well. So he'd come to clinic, everything was great. He would pop in, pop out, everything was great. Then the decision was made that he needed to start to change treatment. This became a real turning point for Sandu, and he disengaged from care for 12 months. On re-engagement to the care centre, he was asked why he stopped coming to clinic. And for Sandu, he was a very proud man. And he actually felt really ashamed that the clinician had chosen to change his medication to one that required him to take food. Now, Sandu being the main provider of his family, disclosed that actually some days he couldn't afford to eat. So he was concerned about actually having the treatment and not being able to eat as a response. So again, it's kind of thinking about sometimes what we think is the reasons why people don't engage in treatment is actually further from the truth. So again, for me, the lessons that I learned from this is to kind of keep the patient at the centre of our decision making. Also involve the patient within the treatment options as well. So what would fit into Sanju's life? What would help him as well? So again, this kind of avoiding assumptions that everybody kind of has access for, even the basics, such as food. And again, there's lots of things that we did do as healthcare providers to help kind of wrap around that support. But again, for me, it was just kind of that lesson that people don't always, for lots of different reasons, usually pride, shame, or embarrassment, kind of can tell you things. And again, it's going back to that building that safe environment. So going back to case study 2, just to kind of fit this in today. So this is Jane. She's a 34-year-old white British female. She was diagnosed HIV positive and struggled with her diagnosis. She was really shameful about her diagnosis and really struggled with kind of what that meant for her. As a result, she didn't confide in anybody around her. She'd not told any friends. She really kind of struggled and she was really tearful. She developed a great rapport with the specialist nursing team, and eventually it came the time that Jane felt ready to start treatment. So Jane went off with her treatment, but next time she came to clinic, her viral load remained unchanged. So it was quite clear from the start that Jane wasn't actually taking treatment. So we discussed this in an open, transparent way, and there was lots of thoughts around why Jane may not be taking a treatment. It may be that she couldn't accept the diagnosis. And actually, when she confessed, she was embarrassed because actually she couldn't read the instructions on the label. And that's why she'd not taken the tablets. And I think for me, this kind of just kind of sums up the fact that sometimes we think we're giving clear instructions, but actually we may not be for the people that is sat in front of us. So sometimes I know I've been very guilty of this in my time, giving lots of information at a time when people may not be in that same place or the right place to receive that information. So again, it's going back to that person-centered way and thinking about actually what information may work for that person. So in Jane's case, we used a lot of symbols and lots of different ways in order to really kind of get her confidence with that. And again, thinking about that social support that was articulated within the literature, people, and definitely from Jane, she didn't have anybody that she could ask, what does this actually say on the bottle? So you may be sat there now thinking, this is all great. You've mentioned loads of different things that I could do if only I had the time. So one thing's for sure, working in any healthcare setting, time is always very limited. That's the wonderful world of the healthcare system that we all work in. So how can I make this better for the people I'm providing care for? So again, this idea of working in a partnership way. So find out what the patient knows already and fill in the gaps. Definitely it's worth, before we kind of think about imparting education, actually what do they know and what do they want to know as well. Again, thinking about working on patients' goals, this kind of concept and this definite person-centered shift from what matters to you rather than what's the matter with you. So again, being flexible with your agenda versus the patient's agenda. And again, this idea of being open and transparent with our communication. So I really like this quote from Pascal from the 17th century. And it states, generally, people are better persuaded by the reasons which they have themselves discovered than by those which have come to minds of others. And that definitely resonates with me. I'm very much better persuaded by all those thoughts that come to my mind. So again, it's thinking about working in that patient partnership way. So just a quick summary to summarise today's presentation. So adherence is important, and it's important to improve the quality of life for people living with HIV. HIV care is very much around ensuring quality of life. Although our medication regimes are easier to adhere to, still so many people have difficulties in achieving and sustaining virological suppression. As previously articulated by Liz, different factors need to be taken into consideration when exploring adherence, again thinking about drawing from the literature. Strategies are available to help patients. These need to be tailor-made to specific needs and patient experiences. Again, this idea, we all know one size doesn't fit all. So how can we be flexible in our adherence toolkit to provide support for people living with HIV? Support improves adherence. Optimal adherence can help contribute to the maintenance of health and quality of life for all. So again, investing that time in working out what helps people living with HIV. And just a final thought from me, given the proper supportive atmosphere, people will naturally change in a positive direction. So thank you very much.